I am in a busy geriatric practice. So my thought today was to try and give you just a broad overview and gestalt of how I think about nutrition in a general visit without necessarily delving deeply into any particular topic. So bear with me and I'll try and look at the chat if you have questions as I go, and I'll try and be quick. So I have no disclosures. The goal today is really to provide a general approach that you can quickly incorporate into an office visit, and then just recognize the complexity of the factors that go into what people eat, the socioeconomic, environmental, and behavioral domains that all contribute, and just introduce you to a general framework that I use in clinic. Ooh, how do I keep going? Here we go. Okay, so Hippocrates, 400 BC, if we could give every individual the right amount of nourishment, oh, I can't see my slides. Not too little, not too much, we would have found, or we will have found, the best way to health. So as we know, diet is a modifiable factor that we can influence for our patients to help them. However, behavior change is hard, and we'll talk a little bit about that. Why is healthy nutrition important? It can prevent disease and disability. We can help with the maintenance of mental health and function. It contributes to quality of life. And it really does play a major role in many of the chronic conditions that we manage. And we know that optimal nutrition can improve health outcomes, quality of life, and preserve independence. So just thinking about the factors that influence nutrition in an older adult. So it's everything from their medical conditions and health status, their oral health, to if they have peripheral neuropathy, what their functional status is, their cognition, are they depressed, these sorts of things. And then external factors, are they homeless, where are they living, what geopolitical thing is affecting their ability to get food. The grain shortage in Ukraine is a great example, or the world grain shortage due to the conflict in Ukraine is a great example. So thinking about all of these complex issues as we think about nutrition for our particular patient. Okay, so we're going to use the 4M framework to apply to how to think about nutrition in a clinic visit. I think you're familiar with this, as there have been presentations on it before by, I think, Dr. Bennett. So what matters, medications, mentation, and mobility. So thinking about those buckets during your geriatric assessment and then your nutrition assessment. So what matters to the patient? It is really the foundation of any behavioral change that you're doing in a clinic setting, as you all know. So elicit the patient's priorities, what their goals are, and how they want you in terms of changing, their diet, behavior, what they're, and that sort of thing. And how can you do that in a productive way? And who do you need on your team? Do you need a dietitian? Does the patient need an exercise coach in addition to a dietitian to meet their goals? That sorts of thing. Okay, so I'm stretching the what matters a little bit here, but what matters in your clinical assessment? Okay, so geriatric assessment, in my mind, includes a solid nutritional assessment. And here's sort of a quick ABCD and clinical frailty scale as just kind of eyeball things that I think we do anyway in clinic, and we can apply them to our nutritional assessment. So as the patient walks in, you assess them, you are seeing, okay, how frail is this patient, or are they very fit? And how is that going to change the recommendations I have for my patient? So ABCDs, so anthropomorphic. So remember to look at the vitals and look at the trend of your vitals. What is the trend in weight? What was a good weight for this person when they were in their 30s and 40s? And how has that changed over time? Remember that normal BMI parameters due to body composition changes in older adults are different. So think, BMI of 23 to 30 is okay in older adults, and and that may not be their perception. And so you have to really talk to them about that and explain what type of weight loss is healthy. Often I end up talking to people a lot about strength training. But biochemical and basic lab workup that you already have is helpful for assessing nutrition. So just general CBC, CMP, A1C, vitamin D, B12, sometimes folate, iron studies, inflammatory markers can all clue you in to the nutritional state of a patient. Are they anemic? Do they have renal dysfunction? What are their electrolytes? What's their glucose tolerance? That sort of thing. It's not necessarily more of an excessive workup. I have a unique patient population, and some of them come in with complex labs that they've had ordered by their naturopath. So just remember that's not always necessary. And then clinical. So when you're obtaining your geriatric assessment, you're getting a good nutrition assessment. And when you're eliciting a dietary specific dietary history, these are the things that, you can ask them, what was a good usual weight for you? When you're asking about, your review of systems, ask about their dentition, ask about their bowel movements. Do they have chronic diarrhea? Did they become lactose intolerant? These sorts of things play into your dietary history. It is sometimes hard in clinic in a short amount of time to get a good dietary history. You can ask them, what do you usually eat during the day? Who goes to the grocery store for you? Ask them, what have you eaten in the last 24 hours? If that is hard to elicit, which is sometimes I have patients bring like a record of what they've eaten for the past 3 days, just as you would for maybe their bowel movements or a urinary diary, that sort of thing. And there are tools like the mini nutritional assessment that you could use in clinic to assess for malnutrition. When you do your physical exam, think about, what is the fat distribution? Where is their muscle wasting? How's their strength? What is their dentition like? Do they have edema? Do they have ascites? These are all things that play into your dietary assessment. Oops. Okay, this is a quick sort of checklist that you can kind of think about, get a gestalt for, and use. So disease, eating poorly, tooth loss, mouth pain, economic hardship, reduced social contact, multiple medications, involuntary weight loss, needs assistance, and the elder years and how that changes diet. This is the mini nutritional assessment. You can sort of see it, but it does kind of account for a few of those things and gives you kind of categories of if they're at risk for malnutrition or if they're malnourished. Medications is a huge one. So I think that this often is a major cause of weight change in patients and their appetite. So polypharmacy, as I'm sure you've heard a lot about, but an optimal prescribing is so important. And thinking about adverse medication side effects and the burden of medications. Make sure you know why a patient is on each medication and when they started it and why they started it and how it might be affecting their weight and their diet and their appetite, if you're concerned about weight loss or weight gain, etc. Polypharmacy is known to be associated with poor diet. So just keep in mind that that's important. And as you know, different medications have different effects on weight. Antipsychotics, steroids, antidepressants, diabetes drugs, SGLT2 inhibitors. Does the patient need one? Is it affecting their weight? Laxatives, diuretics, they all can affect your nutritional assessment, right? So the other thing is, we know that healthy diet impacts brain health. The best research is really for Mediterranean diet. And we also know that nutritional status can be used as a clue to cognitive impairment or mood disturbance. So thinking about okay, why is this person losing weight? Are they losing weight because they don't have the executive function to eat and acquire food and go grocery shopping and cook? And then think about the context of where they're eating. Did a spouse just die? Or did they just move into assisted living and now they eat dessert after every meal? Thinking about, these factors as you're assessing. Mobility. So food acquisition, shopping, and cooking requires a lot of dexterity, mobility. You have to be able to get to the store, etc. So think about those things and functional status overall. Also think about weakness and sarcopenia and sarcopenic obesity, which you may have heard about, but you can have low muscle mass and high fat mass and be quite frail. And that can be challenging and change diet quite a bit. Many health systems screen for food insecurity, and it's important because food insecurity and chronic comorbid disease interact in negative ways and influence each other. And so making sure that acquiring food is possible and healthy food is possible for your patients. Okay, I just briefly want to talk about a framework of how to think about how much of what categories of food people need in very general broad terms. So as we age, we need less calories, like about 100 calories per day per decade. Our needs decrease because of resting metabolic changes, basically, and less activity. Macronutrients. So fat, you can kind of think of as 20 to 35% of our caloric intake. And in general, the quality of the fat matters. So we know that monosaturated and polysaturated fats are better for us. And carbohydrates, I think of as about half of diet, but up to 65% of the calories that we need. And we know that whole grains are better for us. And, you know, in the United States, we eat a lot of refined grain. So just telling people to try and avoid or use baked goods as a special treat can sometimes really help if they're struggling with glucose intolerance. And we know there's a mortality benefit to eating fiber. Fiber is so good for you. And I think about 14 grams per 1,000 calories. So you can kind of say 30 grams of fiber per day as a general rule. As people increase fiber in their diet, their stools change. So make sure that you're also talking to them about fluid intake when you're making fiber recommendations. And then protein is a bit controversial, but in general, I go with 1 gram per kilo per day. And it does not have to be, we get, in general, in the United States, we get enough protein in our diet per day. Older adults have a little bit more difficulty getting enough protein. And if they're critically ill or they have increased metabolic demands, we need to think about more protein. And getting a dietitian involved at that point is a good idea. Those are kind of the macronutrient recommendations. And just in general, I am very much a believer of Michael Pollan's, eat plants, wait, oh my goodness, now my mind is basically eating a plant-based diet is excellent. And we don't do it well in the United States. So what's recommended, as you can see here, is about 3 times the amount of fruit, double the veggies, whole grains, nuts and seeds, and we eat a lot less, okay, than that. Fluids, I tend to tell people to try and get at least 2 liters a day. 48 ounces is a good amount. And this is hard for older adults. They have a decreased thirst response. They're just not as interested in drinking a lot of the time. And dehydration is one of the number 1 reasons for, hospital admission and ER visit. I mean, it's common. So hydration is key. And then salt. So I think a lot of people do know now that salt is hidden in processed food. But I think it's important to remember when you're talking to your patients that eating at home, eating smaller portions of salty food is really important, and using salt substitutes can really help a lot. So I do kind of try and figure out what the patient's willing to do and cut out, but cold cuts, cheeses, that sort of thing actually hide a lot of salt. Okay, and then micronutrients in older adults. So I don't know if this is specifically unique to the Pacific Northwest, but the amount, I mean, it's a $1 billion industry in the United States. The amount of supplements and that people come in on is astounding, right? That you're evaluating. And in general, I don't recommend supplementation unless someone's deficient. The safest, most effective and enjoyable way to obtain vitamins and minerals is food. Occasionally, if people have a low calorie diet or they're low in vitamin D, low in vitamin B12, I supplement. But the best way to obtain vitamin D, calcium is food. Here are some just general references. And I do test for vitamin D, and I do test for vitamin B12. And a key thing about iron is, it really can make people feel extreme. Oral iron can make people very sick, and it doesn't need to be dosed every day. And so just remembering that when you're talking to people, and sometimes people are taking multivitamins with iron and they're nauseous because of that, and you stop it and they think you're a genius, and and feel much better. And it's a small intervention that makes a big difference. I, in clinic, use very simple tools like My Healthy Plate, the Canadian Guide, My Plate for Older Adults, which is out of Tough School of Nutrition. And they're simple, but they work. Label reading is hard for older adults. I don't talk about it very often. I do sometimes talk about it when I'm talking specifically about sodium or added sugar, and to help people kind of who are very detail oriented. So it really depends on the person, but it can help so they get an idea of what they're eating. And then the general trend these days is to recommend a dietary pattern rather than specific, like eat this percentage. There is no macronutrient percentage that is like key. Many different varieties of diets work, but in general, I recommend the Mediterranean diet in clinic, and it's and it should be culturally sensitive. So I may not recommend the Mediterranean diet to everyone, but then I'm talking about a plant-based diet in general. It's easier for people to follow. Eating is social. It should be pleasurable, and restrictive diets in general should be avoided in older adults because you don't really want to limit food intake too much in general, right? I like this website, Old Ways. It's just a really nice kind of visual for people, and they have actually different diets. So I refer to it. And in general, I talk, especially when I'm talking about cognition to people, I talk about the Mediterranean diet. And it's rich in legumes and whole grain cereals, fruits, vegetables, and fish, and lower in meat and dairy intake. And it's just been associated with slower cognitive decline, lower risk of frailty, and functional disability. So that's kind of my quick and dirty this is how I think about nutrition in almost every clinic visit, and people want to talk about it. It's a part of their everyday. So, but that's my general advice, not disease-oriented advice. And I think it's very important to plan as people age as they get functionally and cognitively impaired, how are they going to feed themselves in a way that they're excited about? and works so that they can maintain weight. And often I talk to my patients about maintenance more than loss of weight, if they're functionally doing okay. So just wanted to emphasize that. Questions? Thank you for having me.